vaginal delivery. And the objectives of the vaginal delivery, we will see about the delivery technique, persistent occiput posterior pushing, shoulder dystocia, special population, third stage of labor, lower genital tract laceration and the laceration and the episiotomy repairs. While speaking about the delivery technique preparation, the end of the second stage labor is heralded as the perineum begins to bulge, and the fetal scalpel is seen through the separating labia. Perineal pressure from the fetal head creates the reflexive pushing efforts. The fetal heart rate monitoring continues here. The nuptial cord often tightens with the fetal descent, may lead to the deepening variable deceleration. If the bladder is distended, the catheterization can provide added pelvic space. Dorsal lithotomy portion. The most common, the most satisfactory one. The leg holders or stirrups are often used to assist here. Perineal lacerations also occurs here. Legs are not separated too widely or placed one higher than the other. Legs are not stuffed into the stirrups. This permits the quick flexion of the thighs backward onto the abdomen. Should shoulder the dystocia develop here. The legs may cramp during the second stage pushing. Cramping can be relieved by creating the gentle muscle stretch or brief massage, or they can be done by both. While speaking about the delivery of a head, by the end of the second stage labor, the portion of the occiput is usually known. Molding and the caput formation may have precluded early accurate identification. The occiput anterior or is rotated slightly oblique. This is the most common one. The persistent occiput posterior, which is around the 5%. While speaking about the crowning, with each contraction, the vulvovaginal opening is dilated by the fetal head to gradually form an oviduct and finally almost circular opening. The encirclement of the largest head diameter by the vulvar ring occurs here. While speaking about the method of delivery of head, the first method is a hands-on method. The thumb and the remaining fingers form a V pressed against the perineum to bolster it. The other hand maintains the fetal neck flexion to deliver the smallest head diameter through the introitus and provides a gentle pressure against the rapid forward movement to avoid the explosive delivery. And the second one is hands poised method. The hands touch neither the head or the perineum but are applied only selectively to slow rapid head expulsion. They also causes the lower episiotomy rate. The delivery technique and the delivery of a head. Ricard maneuver. The gloved fingers grasp the fetal chin just behind or in the anus and exert. The upward pressure between the contractions occurs here. As a counter, the other hand presses against the occiput to control the forces against the perineum. Alternatively, if expulsive efforts are inadequate or an expedient delivery is needed here. While speaking about the delivery technique, the delivery of a shoulders, the following delivery of the fetal head, the finger is passed across the fetal neck to determine whether it is encircled by the one or more umbilical cord loops. Nuptial cord incidence. This increases with the gestational age and is found in the early, nearly 25% of the deliveries at term. While speaking about Larson 1997, who said about the nuptial cord incidence, if an umbilical cord coil is felt, it is slipped over the head. If loose enough, if too tightly, the loop is cut between the two clamps. The tight nuptial cords complicate approximately 6% of all deliveries, but they are not associated with the worse neonatal outcomes than those without a cord loop. Delivery of the shoulders. Hooking the fingers in the axilla is avoided. This can injure the upper extremity nerves and produce a transient or possibly permanent paralysis. Immediate nasopharyngeal valve suctioning of the newborn was routine to remove the secretion. Suctioning of the nasopharynx may lead to the neonatal bradycardia. American Heart Association neonatal resuscitation recommendations. They escape most suctioning immediately following the birth, even with the meconium present. Delivery technique, delivery of the soldiers. With meconium stained fluid, routine intubation for the tracheal section is not recommended for the vigorous or for the non-vigorous neonates. Suctioning is reserved for the neonates who have the obvious obstruction to spontaneous breathing or who require the positive pressure ventilation. Suctioning options are bulb syringe or the suction catheter aspiration. This may include the intubation suctioning if the airway is obstructed. Delivery technique for the cord clamping. Umbilical cord is cut between two clamps placed 6 to 8 cm from the fetal abdomen, and later an umbilical cord clamp is applied 2 to cm from its insertion into the fetal abdomen. For the vigorous term units, umbilical cord clamping is ideally delayed 30 to 60 seconds to transfer the blood to the newborn. In general, the delayed compared with the early umbilical cord clamping does not worsen the access course or the umbilical cord pH values. The occiput transverse position. Pelvic shape leads to the persistent occiput transfer. The position is not easily overcome during the second stage pushing the patellar pelvis, the flattened anterior posteriorly. While speaking about the anterior pelvis, this is the heart-shaped one. The space may be inadequate for the occipital rotation to either an anterior or the posterior position. In the absence of the pelvic architecture abnormality of the excitism, the OT position is usually transitory. Hypotonic contraction. The head is usually rotates spontaneously to an OA position. If the rotation ceases because of the poor expulsive forces, the vaginal delivery can be aided. The manual rotation can be done here, and the Keyline forceps also can rotate the occiput anteriorly. When speaking about the persistent occiput posterior position, this is nearly 2 to 10%. Many fetuses delivering the OP or OA in early labor, that is, the male rotate during the labor. While speaking about the risk factors, they are epidural and analgesia, null parity, and greater fetal weight, prior delivery with the OP positioning, and the pelvic shape is atheroid pelvis and narrow subpubic angle. Higher associated rates of the prolonged second stage labor, caesarean delivery, and the operative vaginal delivery. The women who deliver vaginally, higher rate of blood loss and the OCSs. Digital examination for the identification of the fetal head position can be inaccurate. The transabdominal sonography may increase the accuracy here. Shoulder dystocia. Anterior fetal shoulder can become wedged behind the symphysis pubis and fail to deliver with the maternal pushing and gentle axial transaction by the provider. Turtle sign. The retraction of the baby's head against the mother's perineum. The mean head-to-body delivery time in the normal birth was 24 seconds compared with 79 seconds in those with the shoulder dystocia. The head-to-body delivery time greater than 16 seconds be used to define the shoulder dystocia. Shoulder dystocia, maternal and the neonatal consequences, poses greater risk to the fetus than to the mother. Serious perineal tears and the postpartum hemorrhages, usually from the uterine anatomy, but also from the laceration. The neonatal concerns will be here. Significant neuromusculoskeletal injury and the asphyxia, brachial plexus injury, which is nearly 11%, and the clavicular or the humeral fracture, which is 2%. While speaking about the prediction and the prevention, the risk factors, which is the fetal macrosomia, maternal obesity, prolonged second stage labor, operative vaginal delivery, prior shoulder dystocia, maternal diabetes mellitus. Combination of the fetal macrosomia and the maternal diabetes mellitus escalates the frequency of the shoulder dystocia. Planned caesarean delivery, non-diabetic women with the fetus whose estimated fetal weight is greater than 5,000 grams, and the diabetic women whose fetus is estimated to weight greater than 4,500 grams. Shoulder dystocia. While speaking about the management, we can say labor and the delivery team. The first one is the main role played here as the nurses and the obstetrical providers and the anesthesia staff should be well versed in its management. One goal is to reduce the delivery time due to the ongoing cord compression. The second goal is avoiding the fetal and the maternal injury from the aggressive manipulation. And third one is adequate analgesia. This assists the maneuvers. Episiotomy to provide the sufficient room for the essential manipulation, but they does not lower the brachial plexus injury rates. While speaking about the shoulder dystocia management, the various techniques can be used to free the anterior shoulder from its impacted position. The first one is Mac-Roberts maneuver. They are often selected first. The legs are lifted from the stirrups, hips are sharply flexed upon one to the abdomen, and knees remain flexed. While speaking about the second one, suprapubic pressure, during the Mac-Roberts maneuver, an assistant can apply downward and laterally directed. The abducts the anterior shoulder to create the shorter bisacromial diameter. It also rotates the shoulder into the oblique diameter, which at the pelvic inlet is stronger than the anterior posterior diameter. If unsuccessful, moves to move next to the posterior shoulder or to the rotation maneuver. Delivery of the posterior shoulder. A hand into the posterior pelvis carefully sweeps the posterior arm of the fetus forward across its chest and deliver the arm. If possible, the operator's fingers are aligned parallel to the long axis of the fetus humerus to lower the fracture risk. The fourth one, the Rubin maneuver. The rotation maneuvers method recommended by the Rubin aims to shorten the bisacromial diameter. A pelvic hand reaches the most easily accessible fetal shoulder, often the posterior one, which is then pushed towards the anterior surface of the chest. The maneuvers abducts the posterior shoulder and rotates both shoulder into one of the pelvic inlet's oblique diameter. The friction from the vagina also abducts the anterior shoulder to some degree during this rotation. The resolution of the disproportion can free the anterior shoulder. Fifth one is Woodcock-Cleve maneuver. The rotating the posterior shoulder progressively in the cock-cleve fashion, the impacted anterior shoulder would be released. One hand is pressed against the anterior surface of the posterior shoulder and the pressure is directed toward the fetal back. Posterior shoulder is then rotated 180 degree and in doing so, it becomes the anterior portion glimpse. With rotation, this shoulder comes to life beneath and not behind the symphysis and they cannot be delivered here. While speaking about the gaskin maneuver, all four maneuvers, the battalion rolls onto her hands and knees, axial transaction against the head and the neck attempts to free the posterior shoulder. Challenges with this include immobility from the regional analgesia and the time lost in the patient repositioning. Posterior axilla sink traction, first discovered by the Cleaver and Humphrey. This is to deliver the posterior arm. If the posterior arm is inaccessible, suction tubing or the stiff urinary catheter is threaded under the fetal axilla and both ends are brought together above the shoulders. This forms a loop beneath the axilla. Catheter transaction then sweeps upward and outward to deliver the shoulder. Data continue to come in case lies to the 190 cases in which this was the first maneuver which is successful around the 96%. Fracture of the anterior clavicle. By using the thumb to press it toward and against the metanopubic ramus. In practice, however, deliberate fracture of the large neonatal clavicle is difficult. If successful, the fracture will heal rapidly and is usually trivial compared with a branchial nerve injury, asphyxia or death. Symphysiotomy involves the cutting of the intervening symphysial cartilage and much of its ligamentous support to widen the symphysis pubis. Zavanli maneuver. This involves the replacement of the fetal head into the pelvis followed by the caesarean delivery. Capitolin 0.25 mg per space given to produce the uterine relaxation. The operator first turns the head into the OA or OP position, flexes it and slowly elevates it back to the vagina. The caesarean delivery is then performed here. Home birth. With planned home birth of a lower risk pregnancy, the benefits include fewer medical intervention that include the labor augmentation, episiotomy, operative vaginal delivery and the caesarean delivery. Female genital mutilation. This practice refers to the medically unnecessary vulvar and the perineal surgical modification. Parturients with the type 1, 2 and 4 typically require only the routine obstetrical care. Type 3 FGM or with the extensive scarring have the higher delivery risk. Defibrillation, the division of the midline scar tissue to reopen the vulva, also called as the defibrillation or the anterior episiotomy. World Health Organization classification of the female genital mutilation. Type 1, partial or the total removal of the clitoris and the prepuce. Type 2, partial or the total removal of the clitoris and the labia minora with or without the labia majora excision. While speaking about the type 3, the partial or the total labial minora, the majora excision followed by the fusion of the wound termed infibrillation to cover and narrow the vagina with or without the clitotomy. Type 4, the breaking, piercing, incision and the scalping kerchief or other injury to female genitalia. Third stage of labor, the delivery of the placenta. The third stage labor begins immediately after the fetal birth and ends with the placental delivery. The goal is to delivering in the intact placenta and avoiding the uterine inversion or the postpartum hemorrhage. To prevent the uterine inversion, the umbilical cord traction must not be used to pull the placenta from the uterus. Delivery of the placenta. The signs of the placenta separation: sudden gush of blood into the vagina, globular and the femur fundus, outward movement of the umbilical cord as the placenta descends into the vagina, elevation of the uterus into the abdomen. Signs appear within the minutes after the newborn delivery. The median time ranges from 4 to 12 minutes. Management of the third stage, either expectant or the active. The expectant management, waiting for the placental separation signs, allowing the placenta to deliver either spontaneously or aided by nipple stimulation or the gravity. Active management, earlier cord clamping, controlled cord action during the placenta delivery, and the immediate prophylactic administration of the uterotonic agent is needed here. Immediate postpartum care, laceration check and repair here. They give uterotonics. They check for the expanding hematoma. They monitor BP immediately after the delivery of a placenta every 15 minutes for 2 hours. Temperature is recorded every 4 hours during the first 8 hours and then every 8 hours thereafter. Vital signs may be obtained more frequently in patients at the higher risk of postpartum complication. Placenta, membranes and umbilical cord are examined for the completeness and the anomalies. Here we can look for the skin-to-skin contact. They aim to connect the mother and the newborn dead early to promote the breastfeeding. Lower genital tract laceration. The third degree laceration involves the anal sphincter and are subcategorized as a 3A, 3B, 3B, which is 50% greater than 50% and EAS plus the internal and the sphincter ears. The third and the fourth degree perineal laceration are considered obstetric anal sphincter injuries. Episiotomy. Two main types. One is midline and the mediolateral. Midline, they begins at the foreshape, incises the perineal body in the midline and ends well before the ES is reached. Choose an incision length varies from 2 to 3 cm depending on the perineal length, degree of tissue thinning and outlet diameter needs for the delivery. Mediolateral, they begins at the midline of the foreshape and is directed to the right or left at an angle 60 degree of the midline. They require the less time and suture for the repair. The preferred incision to reduce the overseas rates.